Hi everyone, in this video we'll be talking about gonorrhea. Gonorrhea is another sexually transmitted infection and is caused by a bacterium called Neisseria gonorrhoeae, which is a gram-negative intracellular diplococci, GNID bacterium. The symptoms of gonorrhea. Number 1, discharge, urethral in males and vaginal in females. Number 2 is pain, dysuria in males, while dyspareunia with cervicitis in females. 3 is anorectal symptoms, including discharge, irritation, painful defecation, and disturbed bowel function. Number 4 is conjunctivitis, which is purulent and sight-threatening. The complications of gonorrhea. In males, they could have epididymal orchitis, which is a painful red swollen testicle or testicles. In females, they could have pelvic inflammatory disease, PID, including dyspareunia, intermenstrual bleeding, postcoital bleeding, and discharge. Disseminated disease is also a complication that could happen in males and in females, which includes a macular rash that may include necrotic pustules and septic arthritis. Another complication is meningitis or endocarditis, but this is rare, and very rarely there also could be prostatitis in males. The diagnosis of gonorrhea can be done through a nucleic acid amplification test, NAAT, and a culture. The nucleic acid amplification tests can be done through a first-pass urine or a swab, while a culture should be done through a swab. The swabs can be taken from the urethra, anorectal, endocervical, self-collected vaginal, or pharyngeal, according to each case. Always test for culture before treating gonorrhea to determine antimicrobial sensitivity and contribute to antimicrobial resistance surveillance. The treatment of gonorrhea is a ceftriaxone 500 mg intramuscular injection, stat in 2 mL 1% lignocaine, plus azithromycin 1 gram orally stat, increased to 2 grams orally stat in cases of pharyngeal infection. Unfortunately, a reduced susceptibility to the first-line treatment is emerging in urban Australia. If a patient has an intrauterine device, IUD, leave IUD in place and treat as recommended. We should also advise no sexual contact for 7 days after treatment is administered. We should also advise no sex contact with partners from the last 2 months until the partners have been tested and treated if necessary. We should also advise contact tracing for a minimum of 2 months. Provide a fact sheet, notify the state or territorial health department, and consider testing for other STIs. In cases of rectal co-infection with chlamydia, treatment should be given for gonorrhea and chlamydia, which includes a ceftriaxone 500 mg intramuscular injection, stat in 2 mL 1% lignocaine, plus a doxycycline 100 mg orally twice a day for 7 days if asymptomatic and for 21 days if symptomatic. In cases of pregnant women, we do the same as principal treatment. In regional or remote areas, we could administer amoxicillin 3 grams orally stat, plus probenecid 1 gram orally stat, plus azithromycin 1 gram orally stat. And finally, for follow-up, we should review our patient in 1 week, which provides an opportunity to assess for symptom resolution, confirm contact tracing has been undertaken or offer more contact tracing support, provide further sexual health education and prevention counseling. As for the test of cure, TOC, for pharyngeal, anal, or cervical infection, a TOC should be done through a nucleic acid amplification test, NAAT, and should be performed 2 weeks after treatment is completed. Retesting should be done 3 months after exposure. So that concludes this video. Thank you very much for watching. Please like this video, share it with your friends, and subscribe to my channel.